I'm going to be talking about the differences between narcolepsy type 1, type 2, and idiopathic hypersomnia. And you'd think this would be pretty easy, but in practice, it actually turns out to be pretty hard. And in the what I have is sort of a modest number of slides because I hope there's lots of questions. And as you heard, it'd be great if you could raise your questions as we go along here. I also hope that you will don't feel shy, because if you have a question, there's a pretty good chance somebody else has a similar question. I'm realizing I can't see the Q&A if I'm going full screen, so I don't think I can bring that to the foreground. Monica, could you just keep an eye on that, and maybe you could just shout out if there's a question, yes, then I can pop out to it.
Absolutely, yes.
Okay. All right. So what I'm going to be talking about is the official definitions of narcolepsy and idiopathic hypersomnia, how we actually sort of measure symptoms to try to make those diagnoses. I'm going to tell you what we know about the causes of narcolepsy and idiopathic hypersomnia, and then get to actually the important part, is because diagnosis is one thing, but ultimately it's really all about treating people so they can be live as good lives as possible. So these are the official diagnostic criteria for narcolepsy type 1 and type 2. We call these NT1 and NT2. And this is from the International Classification of Sleep Disorders, and it was just revised this summer. Narcolepsy type 1 is obviously a disorder of chronic sleepiness. And in addition to that complaint of feeling sleepy every day, you need to also have cataplexy. And if you have that, we can then do a multiple sleep latency test to provide some additional objective evidence of sleepiness. Or you can do a spinal tap, and we can measure orexin A levels in the spinal fluid. And we're doing that more often now because it's a commercially available test, and it sometimes is a very short and definitive path towards a diagnosis. So what does it mean when we say a positive multiple sleep latency test? Basically, I'll talk about the details of the MSLT a little bit later on, but this is a test where we're asking people to try to fall asleep 5 times across the day. And there's 2 important things that we're looking for on that test. One is to see how quickly they fall asleep. And if you fall asleep in less than 8 minutes on average across those 5 naps, and if 2 or more of those naps contain REM sleep, that's considered a positive multiple sleep latency test. Another thing that was just added to the diagnostic criteria is if on the nighttime sleep study, you fall into REM sleep within 15 minutes of falling asleep, that can be included in the tally towards those naps, but it's also pretty diagnostic in its own right. And so it may stand on its own in that regard. So somebody I see has a question about waking up in the morning, and I'm going to get to that towards the end. So hang on to that for a little bit. So narcolepsy type 2 used to be called narcolepsy without cataplexy, and that's a perfectly fine name still, or you can just call it NT2. These folks also have sleepiness, and they have a positive MSLT. As I'll show you later, there's not much role for testing spinal fluid for orexin in this, because the orexin levels are generally normal. And so this diagnosis of narcolepsy type 2 is very contingent upon the multiple sleep latency test, and that has its pluses and minuses, as we'll discuss. So idiopathic hypersomnia, the third disorder that we're going to chat about, is also a problem of chronic sleepiness. And people who have this sometimes have what we call sleep inertia. And so that's propensity where that's a tendency where it's really just hard to get out of sleep. They wake up in the morning and it takes them a long time to really get up on their feet and start thinking clearly. And sometimes it's so hard to wake up, they need to set multiple alarm clocks or get help from somebody to actually get up and out of bed. In that sense, it's kind of distinct, as we'll talk about, from narcolepsy, where people generally have less trouble getting up in the morning. So in addition to this chronic sleepiness, people with idiopathic hypersomnia have other evidence of sleepiness. We can measure that objectively. And so their multiple sleep latency test also shows a short sleep latency of less than 8 minutes, but they don't have that same strong propensity towards sleep onset REM periods. And so they'll have only 0 or 1 of those naps containing REM sleep. In addition, another way that we can get objective evidence for this is to do a 24-hour sleep study, to record sleep for 24 hours. And if you see more than 11 hours of sleep, that's certainly evidence of the long sleep tendency that's often seen in idiopathic hypersomnia. You could also do this with what's called actigraphy, which is essentially a watch that measures body movement. And if you do that in conjunction with a sleep log, that's also considered reasonably good evidence of long sleep time. So if we see that somebody's really not moving and they log that as truly sleep time, that would also be evidence in support of idiopathic hypersomnia. So Lindsay asks if it's possible to have problematic sleep inertia with narcolepsy and not IH. And the answer is yes. Sleep inertia is way more common in idiopathic hypersomnia, but it certainly does occur. And I'm going to get to that when we talk about this sort of gray zone between the two things, because I've presented this as if it's like super tidy. You got narcolepsy type 1, or you have type 2, or you have IH. And if people fell neatly into categories like this, I wouldn't have much to talk about today. But the truth is everybody's different. And very few people actually fall really tidily into one category or another. I would say there's probably more consistency in the symptoms of narcolepsy type 1, but there's a lot of overlap between narcolepsy type 2 and idiopathic hypersomnia. Greg, I'm going to talk about orexin levels in narcolepsy type 2 in a little bit, because you're correct in pointing out that they aren't always normal. Okay. So let's just talk about some definitions here. And I think these are helpful just to make sure we're all on the same page, because some of these terms aren't super clear. In sleep clinic, when we use the term sleepiness, what we're really referring to is a propensity to fall asleep, especially when you're inactive or sedentary. So if somebody's reading or driving or sitting in a boring meeting or church or movie, whatever, they tend to doze off then. Even the sleepiest people rarely fall asleep when they're physically active. And so I'm not super fond of the term sleep attacks, which is sometimes used in narcolepsy. I mean, yes, when the sleepiness comes on, it can be very intense, but people aren't, people almost never suddenly collapse with sleep in the midst of actively doing something else. They fall asleep when they're kind of inactive and quiet, just like anybody who is super sleep deprived might. Now, fatigue, I think, is a term that's helpful to refer to feelings of low energy. But in the strictest sense, if somebody's fatigued, if they're resting, like lying on the couch during the day, they might not doze off. And so somebody with actual, like real chronic fatigue syndrome would say they spend a lot of time lying down, but they don't actually fall asleep during that. And so in the extremes, sleepiness and fatigue are different. Having said that, there certainly is some blurriness between that, because sometimes people who are sleepy also have fatigue and they'll have feelings of low energy and just need to rest for a while, but they may not doze off, and vice versa. Sometimes people come into clinic saying they feel tired, and that can mean anything. And so we try to sort of pin them down on exactly what they're referring to, because sometimes with fatigue or tiredness, actually they're referring to muscle weakness, like you might see with other neurologic disorders. Sleep inertia, I touched on already. And this is, so it's almost as if the sleep doesn't quite end even when you wake up. People feel groggy, they feel confused. And if they allow themselves and they close their eyes and lay down again, they'll go back to sleep in a flash. And in healthy, normal individuals, everybody's got a little bit of this. If your alarm goes off, it may take a minute or so to kind of get your wits about you, or if the phone rings in the middle of the night. But in people with idiopathic hypersomnia, this can be really bad, and they can feel just addled like this for an hour or two upon getting up in the morning. Actually, this is a good place to just highlight something. This is really my clinical impression rather than any sort of scientific consensus or anything. But I think one important feature that we'll get to, as you'll see in the subsequent slides, is that in narcolepsy, people have trouble staying awake. In idiopathic hypersomnia, people have trouble waking up. And that's maybe putting it way too simply. But in some ways, I think in idiopathic hypersomnia, one of the biggest things that people really describe is just how hard it is to get up in the morning. Whereas for people with narcolepsy, getting up in the morning is often not that much of a struggle. But they can certainly transition from wakefulness to sleep very easily. But People with IH may not have quite the intense imperative sleepiness that narcolepsy folks can have. That's just broad strokes. As I said, everybody's a little different. All right, so how do we actually measure sleepiness? Because it's all fine for somebody to describe their sleepiness, and when they come into clinic, first thing I do is I ask them, well, give me a sense of how this impacts your day, and just speak in sort of loose terms about how the sleepiness impacts their driving or their social life or their schoolwork and things like that. But then we want to try to put a number on it, and so we try to measure sleepiness. And so we use a number of things. Some of these, I suspect some of the folks on this who are listening now have actually done themselves. The most common is the Epworth Sleepiness Scale. I'll talk about that in a second. And then there's the Stanford Sleepiness Scale. Those are just very simple little questionnaires that can give sort of a rough estimate to how sleepy somebody is. We also like to objectively measure this because it's good to have hard data to measure sleepiness. And so the multiple sleep latency test, which you've already touched on, measures the ability to fall asleep. There's another test called the maintenance of wakefulness test, which measures your ability to stay awake when you're instructed to stay awake. And so we'll get into those in a little bit. It's also good to document the timing and duration of sleep. And so for that, we use actigraphy, which, as I mentioned, is traditionally done with a little wristwatch that measures your body and arm movements, and a sleep diary where people log when they go to bed, when they get up, et cetera. Somebody named Rem said that I had said that in people with IH, people can really struggle to wake up. And is that same difficulty seen with narcolepsy type 2? And the answer is sure. Yeah, and it's again, those people who sort of fall into that gray zone between narcolepsy type 2 and idiopathic hypersomnia. So yeah, I agree. Some people with narcolepsy type 2 do have difficulty waking in the morning. Okay, so the Epworth Sleepiness Scale. This is really a very commonly used tool in sleep clinic. And it's really supposed to be kind of an overall average measure of how sleepy you have been over the last week or so. They don't really specify that time interval, but I usually ask people, in the last week or so, what's happened? And we ask, how likely are you to actually nod off or truly fall asleep in the following situations? And I like to kind of push it to the point of I really mean falling asleep, not just feeling drowsy, because a lot of people can feel a little tired, but just to kind of put a firm definition to it, truly fall asleep, unconscious, eyes closed. And we ask them for each of these questions, would they never nod off? Is there a slight chance, a moderate or a high chance? And so you then go through these various circumstances like sitting and reading, watching TV, sitting in a public place like a meeting, et cetera. And for each one of those, you can have 0, 1, 2, or 3 points, and then we add it all up. And in general, healthy individuals score somewhere in the 0 to 10 range. People who are mildly sleepy score in the 11 to 14 range. 15 to 17 is considered moderate sleepiness, and scores of 18 or higher are considered indicative of severe sleepiness. And that actually can help sort of drive our treatment decisions. If I see somebody in clinic who's got what I think is mild sleepiness, I might pick different medicines than somebody who's got a Epworth score of 20 or something like that, where they're severely sleepy, and there's clearly a lot of impacts, and we might want to actually try a more potent medication. Another person is asking, can you have narcolepsy type 2 and idiopathic hypersomnia at the same time? I would say probably not. I think if that's the case, it's really more a question of that somebody has symptoms of both, and they may sort of fall along this spectrum. But I didn't actually say this initially, but narcolepsy type 1 and 2 together affects about 1 in 2,000 people, but idiopathic hypersomnia affects about 1 in 20,000 people. And so the odds of actually having them both together would be really, really slim. So I think that if somebody's got symptoms that sort of fall into both categories, it's that they fall into this sort of spectrum region, this gray zone between the two diagnoses, rather than actually having two separate disorders. Somebody asks, can narcolepsy type 1 have the same problematic sleep inertia as an IH? And again, maybe I have to say, I don't think I've really seen it a whole lot, and there may be some papers written on this. I can't think of any offhand, but I have to say my impression talking to people in clinic is generally if somebody's got true narcolepsy with cataplexy, low orexin levels, usually it's not that hard for them to wake up in the morning or after a nap, but there's always exceptions to that. Okay. Oh, should the Epworth be, that's a good question. Should the Epworth be answered on medicines or without medicines? And that's a great point because it depends on what the purpose is. I think for the initial diagnosis, we want to do the Epworth in a clean state with no meds confounding it so we can get a sense of what the disease itself is doing. We'll continue to check the Epworth on subsequent visits to get a sense of how effective the medicines are. And so, if somebody comes in with an initial Epworth of 18, then we put them on some medicines, and then on the next visit, it's down to 12. That's pretty good progress. And maybe we'll add a little bit more, adjust the medicines, but maybe we'll just say 12 is good enough, and we can keep going with that. So yes, it depends on the circumstances. So many good questions. I may regret saying I was going to answer these as we go along. Let's see. Are narcolepsy type 2 and idiopathic hypersomnia hereditary? So yes, there is a genetic association with narcolepsy type 1 and type 2. I'm not going to really get into it in this talk, but there's a certain human leukocyte antigen that runs with that. And idiopathic hypersomnia, however, doesn't have as much genetic predisposition. Any sort of genetics there the studies have been rather weak and unrevealing. It doesn't appear to be nearly as strong an association as in narcolepsy. One important thing to keep in mind, however, is that while there is this genetic influence, it's still kind of uncommon for narcolepsy to run in families. Overall, maybe 5% of people have a family member with narcolepsy. But when people are concerned about whether their kid might develop narcolepsy, like if a mom has narcolepsy, there's actually only about a 1% chance that her child will have it. So it's real, but it's not a huge concern. Okay. Jan, I'm going to hold your question till the end when we talk about specific medicines. All right, so Stanford Sleepiness Scale. Remember the Epworth is sort of averaging across the last week or two. This is a test that's measuring how sleepy do you feel right now. We don't really use this in clinic so often, but I do think this is kind of handy under other circumstances. Like it's great if you want to monitor sleepiness across the day. So you're wondering like, okay, somebody says they're sleepy. Well, how do they feel in the morning versus the afternoon and the evening? And so this is a test that you can do, individually several times a day. So you could even add these results to a sleep diary to help provide some feedback on optimizing your meds. And this is super easy. It's literally one question with 7 possible answers. So you ask, how alert are you feeling at this moment? And a 1 means you feel great, active, vital, alert, wide awake. 7 is you're in this sort of dreamy reverie. You're going to fall asleep soon and you're losing the struggle to stay awake. And then there's all kinds of intermediate values there. And so I think this is handy to get a sense of people's alertness at that moment. Okay, now here's a new scale that just came out a few years ago, which I'm actually very fond of. This is called the Idiopathic Hypersomnia Severity Scale. And what I like about this is that the other ones, the Epworth and the Stanford Sleepiness Scale, are very nonspecific. They're just really meant to measure sleepiness. But this is really meant to be a tool to assess how somebody with IH is doing. In its most narrow form, it's really meant to ask, you got somebody, let's say at the time of diagnosis, you have them fill out this scale, you then put them on medicines and you're going to measure how much have they improved. And so it really focuses on some of the key symptoms that are central to idiopathic hypersomnia. It's not really meant to be a diagnostic tool per se, but it's okay that way too. And so there's 14 questions, and I didn't have space to list them all here, but they focus in on things like, what's your ideal duration of nighttime sleep? How much sleep do you need at night to feel your best? Do you have sleep inertia? So how hard is it to wake up and function properly? Do you take long naps? And then do you feel rested after those naps? Do you have an impact of your IH on the driving and other daily tasks? And on this scale, scores less than 22 are normal. 22 to 30 is kind of typical values for IH patients who are on some sort of treatment. And many untreated IH patients have scores above 31. So I mentioned sleep diaries before, and here's just a very typical one that comes off of the American Academy of Sleep Medicine website. And it's really simple. Each row is 1 day, and you just sort of indicate on, on each row when you go to sleep, when you get up, and you can put down if you've had caffeine and things like that too. It's pretty self-explanatory. And we ask people to do these before they have a multiple sleep latency test, so we can make sure they're getting enough sleep. But it's also kind of helpful, even sort of later in the course when we're managing medicines and so forth, to get a sense of how consistent somebody's sleep schedule is and just how much sleep they're getting, because everybody's busy and sometimes people aren't getting enough sleep, and not getting enough sleep in combination with something like narcolepsy is really tough, because now you have double the reasons to feel tired during the day. All right, let's talk about the multiple sleep latency test in a little more detail here. So this is a test that was invented about 30 plus years ago. And people are instructed to try to fall asleep. And so typically they have a overnight sleep study the night before. They stay in the sleep lab, and on this day, every 2 hours, they're asked to try to fall asleep. And so generally, if you're woken in the sleep lab at 6 or 7 in the morning, the first one will be at like 8, then 10, noon, 2, and 4 across the day. And what happens during each one of those, it's a 20-minute opportunity to try to fall asleep. And the technician will measure how quickly you fall asleep and whether the naps contain REM sleep. And those are referred to as sleep onset REM periods, or SOREMs. As I mentioned earlier, the multiple sleep latency test is considered consistent or supportive of narcolepsy if the sleep latency is less than 8 minutes and there's at least 2 naps containing REM sleep. It's really important to make sure that somebody sleeps adequately the night before, and that's why we do the overnight polysomnogram, because it helps us measure their sleep. The problem is that 6 hours of sleep in the sleep lab is considered adequate, but for most people that's not adequate. It's definitely not adequate for kids. It's almost definitely not adequate for people who tend to be long sleepers. And so I think when possible, it's nice to work with your sleep doc and the sleep lab to see about, maybe if you're going to have one of these tests, and if you're somebody who normally sleeps 10 hours at night, make sure that they get you to bed early enough that you can actually get something close to your normal 10 hours before you have the multiple sleep latency test the next day. It's not always possible just due to scheduling issues in the lab, but it certainly would be something worth striving for. Okay, so there's some pretty important things that need to be done even before the multiple sleep latency test is conducted. And I really emphasize these because it's not uncommon for people to not get proper instructions and to come in for their test and something's been messed up and we either can't do the test or the test is somehow contaminated. One of these is that we don't want people taking any medications that can alter REM sleep. And the most common of these medicines is antidepressants, but there's many others. And so if somebody's taking, say, Prozac or fluoxetine, we want them to be off of that for 3 weeks because it takes that long to wash the medicine out of the body. Wake-promoting medications, like the ones that we use in narcolepsy, like modafinil or Ritalin and things like that, you really should wash out of those for about a week, again, so that we can get you at your sort of natural state. The multiple sleep latency test is really done diagnostically. And so in general, we want people to be as close to their unmedicated state as possible. It's also important to make sure that you got plenty of sleep, because last thing we want to do is to be measuring these things in somebody who's chronically sleep deprived. And so we want to have a sleep log and sometimes even actigraphy running into that for at least a couple of weeks beforehand to make sure that we have a sense of that pattern of sleep and the amounts of sleep. So multiple sleep latency test is how quickly you fall asleep. The maintenance of wakefulness test is just the opposite. And this is a tough test. So how it works is that the individual is told to try to stay awake for 40 minutes. This is done 4 times across the day while sitting comfortably in a chair in a dimly lit room doing nothing. Sometimes it's done sitting up in bed as well. And what we measure is, in this person who's trying to stay awake, when do they actually fall asleep? And we don't use this test diagnostically. That's not its purpose. It's really used in sleep clinic to show that somebody's sleepiness is under control with medications or whatever else we're doing. And so sometimes this is an important test to do to show that somebody is fit to drive, because, like if for some reason or another, somebody with narcolepsy loses their license, the motor vehicle agency might insist that you need to show some objective evidence that their sleepiness is under good control. This test is also used quite commonly in clinical trials to show the efficacy of medications. And the reason for this is because it's just a really stringent, tough test. And here's, just to give you an example of this, I'll show you the typical values at the bottom. Remember, you're supposed to stay awake for 40 minutes, but people who have narcolepsy that's not on any medications, type 1 narcolepsy that is, even though they're trying to stay awake under these super boring circumstances in a dimly lit room, they still fall asleep in 3 to 5 minutes on average. People on medicines can stay awake on the currently available medicines, typically stay awake something like 5 to 10 minutes. And in the general population, people still don't stay awake for 40 minutes oftentimes. Sometimes they do, but on average, they fall asleep between 30 and 35 minutes. It's just, as I said, it's really boring and it's easy to doze off. And if you even fall asleep for, 15 seconds, that counts. And we'll score that as the onset of sleep. So I've heard many people with narcolepsy describe this as a really challenging test because the sleepiness becomes quite intense. Okay, so, in clinic, if we see somebody who has chronic sleepiness, we certainly think of narcolepsy or IH, but we also try to consider, could there be something else that's causing the chronic sleepiness? Across the general population, insufficient sleep is the #1 cause of sleepiness. The average working age American gets about 6.7 hours of sleep on a typical weeknight. In underrepresented minority groups, it's even less than that. So actually, I think it's something like about 30–35% of the general population gets less than 6 hours of sleep. And amongst African Americans, it's almost like 50%. So this is a really pervasive problem. We want to ask about possible disorders that could cause poor quality sleep and disrupt sleep. And so these are also very common. Obstructive sleep apnea, which affects 5 to 10% of the population. Periodic limb movements, where people have these twitchy movements that disrupt their sleep. Pain, other things that can just sort of make people uncomfortable, really horrible home sleeping environment that's noisy or has, various things disrupting your sleep. Those are all factors we need to consider. We also want to ask people about whether they could have a circadian rhythm disorder. Okay, so this is where your body clock is a little out of sync with when you're actually trying to sleep. And so the most common of these is called circadian phase delay disorder, where your body clock runs late. And so it's easy to stay up late, but it's hard to wake up in the morning. Super common amongst, college age kids. And I mention this importantly because this is another disorder where people can have a really hard time waking up in the morning. If your internal body alarm clock isn't going off when you're trying to get up at 7 and it doesn't go off until 10 in the morning, you're going to struggle to wake up because your circadian rhythms are out of line with how you're actually sleeping. Of course, any sort of sedating medicine can cause chronic sleepiness. Benzodiazepines like Valium, antipsychotics, epilepsy drugs, and there's a long list of these things. Even antidepressants, can sometimes be pretty sedating. There's a variety of neurologic disorders that can contribute to chronic sleepiness: Parkinson's disease, Alzheimer's, multiple sclerosis. About a quarter of people with traumatic brain injury can have chronic sleepiness. Prader-Willi syndrome, those kids can have very bad sleepiness. And sleepiness runs a lot with psychiatric problems like depression, anxiety, schizophrenia. In my clinic, we actually see a lot of overlap between chronic sleepiness and some of these problems. And it's often really hard to tease them apart because, when people are depressed, their motivation may be low. It might make it hard to get out of bed. And it's sometimes hard to tell. Are they having trouble getting up because of the depression and their motivation? Or is it because their sleepiness is just so crushing? And even with anxiety, if somebody's feeling anxious all day, that's just plain exhausting. And they just sometimes hit the wall towards the end of the day and just need to crash. There's also some medical disorders which occasionally cause sleepiness. Hypothyroidism, where you're not making enough thyroid hormone. Adrenal insufficiency, where the adrenal glands aren't making enough of their hormones. Kidney problems, liver problems. And there's actually some evidence that just being overweight or obese itself can cause at least some sleepiness. So let's switch to causes. And we'll start off with narcolepsy type 1, because here's a place where we can actually really provide some very concrete science. Until around the year 2000, people had no idea what caused narcolepsy type 1. But then Emmanuel Mignot, Jerry Siegel, and others found that orexin levels were low. And then they and we looked at the brains of people who have narcolepsy and compared them to control individuals, so people without narcolepsy. And if you look at the middle part of the brain, called the hypothalamus, this is where the orexin-producing neurons sit. And in a control individual on the left there, you can see each little dot there represents an orexin-producing neuron. And across the whole brain, these are little, what I'm showing you here is one little slice through the hypothalamus, but across the hypothalamus, there's about 80,000 of these orexin neurons in a healthy individual. But in narcolepsy type 1, there'll be maybe 4,000. There's like a 90 to 95% reduction in these cells, just a scattering of cells. They're still in the same place, but their numbers are much fewer. And as I'll mention in a moment, we think these cells are killed off by some process. Of course, we can't take tissue from this region. It would be way too dangerous and damaging. You can't image this with an MRI scan because the rest of the cells in this area are fine, but we can measure orexin levels in spinal fluid. And this gets to one of the questions that came up earlier of how did narcolepsy type 1 and type 2 differ. So starting off on the left here, you can see orexin A levels in control individuals. And let me just back up a second and tell you what this is. So orexin A is a signaling molecule in the brain. It's produced by neurons and released, and it activates other neurons that help wake you up and control REM sleep. It's a neurotransmitter. And there's two orexins, orexin A and B. There's really not any good, easy ways to measure orexin B now, but it's also reduced in the brain. But we can measure orexin A in spinal fluid. And so this requires a lumbar puncture, where a doctor puts a needle into the low back, draws out some fluid, and then that's sent off to a lab. And usually within a few weeks, you get the result. In control individuals, orexin levels are variable. They go anywhere from sort of the low 200s up to the 600s, but on average, they're about 320 picograms per mil. Picogram is picogram's a very small amount. It's hard to measure these things because there's minuscule amounts in spinal fluid. While we're talking about controls, I'll just point out that it's possible that this natural variation in control individuals actually correlates with some sleep features. And so in a rather small sample, we found that people who have high orexin levels, but are still otherwise normal, take longer to go into REM sleep at night compared to those with lower, but still normal levels. So in narcolepsy type 1, the levels of orexin in spinal fluid are almost always low. About 90% of the time, the levels are below that lower dashed line, which is considered the cutoff. It's 110 picograms per mil. And it's a little hard to see here, but there's a whole bunch of dots mashed together there, each representing one individual. The horizontal line represents what's called the detection limit, in that the assay can't even measure values below 40. And so everybody's just clustered together below that if they had no detectable orexin. And what you can see here is that about 90% of people have these very low levels. But amazingly, there are some people with narcolepsy type 1, about 5 or 10%, who actually have values up in the normalish range. And it's not, honestly, I can't give you a clear explanation for what's going on there. In narcolepsy type 2, we don't have as much data, but there's been others. This looks rather small. This is only showing 20 subjects, but there's been many more described since then. In narcolepsy type 2, 90% of the time, the orexin levels are normal. That is, they're above 110 picograms per mil. What this slide doesn't capture is that we do tend to see more intermediate levels between 100 and 200. But to have truly low levels, less than 110, would be very unusual. And to be honest, by the new diagnostic criteria, that would automatically force a diagnosis of narcolepsy type 1. You would be considered orexin deficient. And whether or not you actually notice cataplexy, you'd be put into that category of narcolepsy type 1. So, oh gosh, I just realized there's all these questions accumulating. Let me finish this thought and I'll come back to some of those in a moment. Okay, but if narcolepsy type 2 isn't caused by a loss of orexin signaling, what does cause it? One possibility is that it truly is also some kind of damage to the orexin neurons, but it's only a partial loss. Remember, in narcolepsy type 1, there's like a 90 to 95% loss of those cells. And maybe this is just partial loss. The trouble is we just have almost no data on this. There was one paper describing brains from 2 people with narcolepsy type 2. One of them had 33% loss, another one had an 85% loss of the orexin neurons. About 20% of type 2 patients have low orexin levels, and about 13% of type 2 patients have them in this intermediate range, as I mentioned. And if you actually follow those people who are clinically diagnosed as narcolepsy type 2, but they have intermediate or low orexin levels, about a third of them will actually go on to develop cataplexy years later. It might be a year, but it can be as many as over 20 years later, they'll have their first episode of cataplexy. And this would suggest that maybe some people with narcolepsy type 2 have had, let's just say for the sake of argument, a 50% loss of the orexin neurons, and it's enough to cause sleepiness, but not enough to cause cataplexy. And but maybe their orexin level is kind of lowish, intermediate, but then perhaps if that cell loss continues, maybe they can go on to have further declining orexin levels and manifest cataplexy later. We just don't have good longitudinal data to measure orexin levels over time to see if that is in fact the case. It's also possible and equally plausible that this is not due to a loss of the orexin neurons or the orexin peptides, but it's really more of a problem kind of akin to what you see in type 1 and type 2 diabetes. In type 1 diabetes, the insulin producing cells are lost and people have very severe symptoms. But in type 2 diabetes, people are still making insulin, but they're no longer sensitive to it. And so you end up with very severe symptoms with loss of insulin, but moderate symptoms if you're just insensitive to it. And so maybe, and again, this is just speculation on my part, maybe people are making orexins, but the downstream cells are just not responding to them as vigorously as they should. And of course, it's also possible that they're just similar symptoms for completely different causes, and this has nothing to do with orexin signaling. Okay, I'm going to answer some questions after this next slide. So what actually causes idiopathic hypersomnia? And here, there's even less to say because I didn't mention this earlier, but the term idiopathic means we don't know what causes it. And that's still, I think, the most honest answer. We don't know what causes idiopathic hypersomnia. But there's a few theories. The one that's actually received the most attention and sort of scientific research is that maybe there's sort of an enhancement of GABA signaling. You might be familiar with this idea of GABA. It's a neurotransmitter in the brain, and GABA promotes sleep. So the main sleep promoting neurons use GABA to turn off other brain regions. Benzodiazepines like Valium and so forth enhance GABA signaling, and they make you feel sleepy. And in fact, other insomnia medicines like Zolpidem also, it enhances GABA signaling too. And so there's been this idea rattling around that maybe people with idiopathic hypersomnia have some chemical in the brain, kind of like, if you will, a naturally produced Zolpidem or something like that enhances GABA signaling. And so the Emory group has done some research on this, investigating whether medications like flumazenil and clarithromycin that reduce GABA signaling can improve sleepiness in idiopathic hypersomnia. And I'm not going to get into the details of that today. They did see some subjective improvements in sleepiness, but there's not as much objective improvement as we'd like to see. And so I think currently there's some docs who try these medicines, but the knowledge base to help recommend them isn't quite as strong as with some other meds. Another possibility is that perhaps idiopathic hypersomnia is due to some kind of chronic inflammatory situation. I think we all have experienced that when you have a really nasty infection, like a bad flu or COVID or something, you get really sleepy. The immune system produces these chemicals, in fact, that produce sleepiness. And so, sometimes in clinic, we hear people who have a story like idiopathic hypersomnia, and they also describe that they have some chronic inflammatory problem with their joints or intestines or something like that. Another possibility is, I mentioned earlier that sometimes, we see this overlap with depression, and people with depression can have some sleepiness. And I sometimes wonder, it's like, maybe in some people, in most people with depression, sadness, feelings of guilt, worthlessness, and so forth are really the prominent manifestation of it, but the sleepiness is not so big, and it's really easy to diagnose depression in them. But maybe in other people who have something that's perhaps neurochemically similar. It manifests more as sleepiness without much of the mood stuff. And again, that's just me speculating, but we certainly see these traveling together, and it's certainly worth asking people about whether this could be a contributor. Okay, let me just take a break here to address some of the questions. So somebody asks, after a big emotion, like after an argument, sleepiness can be so heavy where the rest of the day is sometimes a write-off. Is this normal for narcolepsy? And I actually think that kind of tucks into the thing I said before about how like anxiety can be exhausting. Really intense emotions. I think anybody who, comes home from some like horribly, traumatic event or a really moving thing like a funeral or something, you can really feel washed out. And so I think that, intense emotions are certainly tiring, and it's going to add on to your baseline sleepiness. Another person asks, saying, I was diagnosed using an MSLT without being told to go off antidepressants, and what might have been an error. And I think it depends on what the doctor was trying to do. So the antidepressants can interfere with the manifestation of REM sleep during those naps, and that could be a problem. But sometimes a doctor might do the multiple sleep latency test just to try to get an objective measure of sleepiness. And if that's the case, then the antidepressants are probably not too big a contributor. But it's in a perfect world, we'd love people to come off of any of these psychoactive medicines so we can see what their brain is doing all by itself without any of the meds confounding the picture. Okay. So, and actually, I do want to sort of respond to somebody's comment here, which is that I don't have one of these sleep disorders, and so I can't walk in those shoes exactly. I mean, I certainly hear people's stories, but I certainly can appreciate the fact that feeling super tired has a big impact on your life, and it's not at all unexpected for people to feel depressed. So I don't mean to say that I'm minimizing this at all, because we're going to talk about the life impact in the next few slides, but it's definitely a rough path. Okay. Okay. I'm going to get to this next question on the next slide here. Somebody was asking about limitations of the multiple sleep latency test. And as you know, from those official definitions that I mentioned earlier, the diagnoses really hinge a lot on the multiple sleep latency test. And we know from large studies that this test, while it's good in some ways, it is useful for getting an objective measure of propensity to fall asleep and so forth. It's got some issues. And so, for instance, if you just take a whole bunch of people off the street, sleep deprived, on medicines, all the usual things, 2 or more sleep onset REM periods are found in 13% of men and 6% of women. And this is probably because they're taking medicines that influence the occurrence of REM sleep, or even sleep deprivation itself can cause REM to occur during the day in these naps. Now, if you look for 2 or more sleep onset REM periods and falling asleep in less than 8 minutes, that's seen in 6% of men and 1% of women. Now, that's right there, that meets the diagnostic criteria for narcolepsy. And yet I really have a hard time believing that 6% of men actually have narcolepsy. And so I think that this is sort of a testament to the fact that you can have what are called false positives, where the test is giving you an answer that looks like narcolepsy, but there's maybe something else contributing to it, such as insufficient sleep or sleep apnea or something like that. So another issue that comes up with the multiple sleep latency test is you'd think if somebody's got a diagnosis, they should have it consistently, month after month. But when people repeat the multiple sleep latency test in the same individuals, 6 months later or a year later, in narcolepsy type 1, you get very similar results 80 to 90% of the time. So if somebody had 2 sleep onset REM periods and a short sleep latency, 80 to 90% chance you're going to see that on the second time you do the test. However, in narcolepsy type 2, those 2 tests match with similar results only half of the time. And in idiopathic hypersomnia, it's even worse, where it only matches 25% of the time. And one of the biggest sources of variability there is whether or not you have 2 or more sleep onset REM periods. And this is, it's kind of luck of the draw to some degree, right? You either go into REM or you don't. And sometimes it happens, and sometimes it doesn't. And so I think that's where a lot of the twitchiness comes from. And it's big, because it's like, if you have 2 sleep onset REM periods, now you meet criteria for type 2 narcolepsy. If you have only 1, now you're in the idiopathic hypersomnia camp. On the other hand, the multiple sleep latency test can be falsely negative about 20% of the time, where we take somebody where we clinically are sure that they have some sleep disorder like this, and yet they don't fall asleep very fast, or they fail to have the REM sleep during the naps. And, any of you have had a multiple sleep latency test know there's all kinds of ways for this to go wrong, right? Maybe you're just uncomfortable. Maybe it's the wires on your head. Maybe it's noise in the hallway. Maybe you're feeling anxious. Maybe the meds weren't tapered properly. If my personally, if I have a patient and the first multiple sleep latency test is either messed up or it comes back negative, and it just doesn't line up with the patient's story, we'll just do the test again. And then another point is, we talked about how in narcolepsy type 1, cataplexy is part of the diagnostic criteria, but it doesn't always show up in the first time. It's in general, people get sleepiness first, and then the cataplexy follows some months later, but sometimes it shows up years later. And so it's, that just, again, contributes to trouble pinning down a diagnosis. Cataplexy tends to be really bad when narcolepsy occurs in childhood. They can have lots of cataplexy. It can be long-lasting and quite severe. But as people get to their middle age and older, cataplexy tends to get milder. It's not triggered quite so easily, and when it does occur, it tends to be milder. I have had some older patients with really bad cataplexy, but I think as a general rule, it's not quite as intense as what kids experience. Okay, so Shelley asks, since the MSLT is the only test to determine if someone has NT2 or IH, and it's unreliable, and having an IH diagnosis prevents patients from access to narcolepsy meds, why hasn't IH been coded or listed as some form of narcolepsy? It seems like they're more of a spectrum. And do you think this might be something that'll happen in the near future? Shelley, that is a great question, and it's a source of tremendous debate, because the official diagnostic categories are meant to be used clinically. And they're also, at the same time, people want to try to use them scientifically to try to, really define diseases as accurately as possible. But in the end, we got to make sure that patients are taken care of and that their meds get paid for. And so I'm going to touch on this a little bit later, but it's, I think in the extreme, there are some people who have really clear-cut type 2 narcolepsy. There's some people with very clear-cut idiopathic hypersomnia, and then there's a pretty large bunch that fall in between. And sometimes we'll actually sort of nudge the diagnosis a little bit towards narcolepsy if the insurance, for instance, won't cover because of an IH diagnosis. Sometimes it's just, you got to do this just to get the treatments. Lindsay asks, could this difficulty with reproducibility be due to inconsistencies and improper instructions? And absolutely, yes. The American Academy of Sleep Medicine came out last year with new guidelines to really try to reinforce to sleep doctors and sleep labs just how the MSLT should be done. And the hope is it will be done better, but you would be surprised at how many times I'll see a patient, from another clinic, and we recognize that something wasn't done right, where they didn't get a lot of sleep the night before, they were still on their antidepressant or something like that. Okay. All right, let's move on a little bit here. So here's a table that summarizes these little diagnostic things. And this is just meant as a little sort of wrap up before we go to the last chunk here. So excessive daytime sleepiness, of course, is seen in type 1, type 2, and IH. Cataplexy, of course, is seen in only type 1. Orexin deficiency, so low cerebrospinal fluid levels of orexin, is found only in type 1. 2 or more sleep onset REM periods are found in narcolepsy, but not IH. Long sleep, meaning really more than 11 hours night after night, is relatively, but certainly it's very rare or non-existent in type 1. Pretty uncommon, I should say, or non-existent in type 2 to have such long sleep night after night, but it is fairly common in idiopathic hypersomnia. Sleep inertia, rare in type 1, occasional in type 2, and pretty common in idiopathic hypersomnia. And so here you can see where a lot of this murkiness comes from, right? Because, everybody's different. And so, yeah, people, sleep inertia can occur in type 2. And so I certainly appreciate that there's this continuum between these. Okay, so this is just trying to put some numbers on this of narcolepsy type 1, type 2, IH, and insufficient sleep, and how they compare in terms of sort of sex differences, sleep latencies, naps with sleep onset REM periods, and this gene that I mentioned that runs with narcolepsy called DQB1*0602. So as a general rule, we say that narcolepsy occurs in sort of equal numbers of men and women, but depending on the studies, the numbers are variable. I think IH is somewhat more common in women. Insufficient sleep is pretty equal in both. People with narcolepsy type 1 fall asleep really quick on the MSLT, average of 2.6 minutes. NT2 is about 4 minutes, IH about 5 minutes, and insufficient sleep 7 to 8 minutes. Multiple sleep latency naps with sleep onset REM periods are very common in the narcolepsies, very uncommon. Actually, that should be 2 or more sleep onset REM periods. So IH patients rarely will meet that criteria. And what you can see there is that that HLA gene, super common in type 1 narcolepsy, medium frequency in type 2, suggesting some genetic influence there, and less common in the general population. Those numbers, 12 to 25%, are the same as what you'd see in any sort of random sample of the general population. So we end up with this borderland where people just don't fit neatly into categories. And so I just want to emphasize a few of the points that provide sort of, also I call it softer endpoints. Like with napping in type 1 narcolepsy, people often have very short naps, 15 to 20 minutes, and they really wake up feeling good and ready to go. With idiopathic hypersomnia, if they do nap, they tend to be long naps. It can be an hour, it can be 3 hours, and they don't feel refreshed. In fact, sometimes the naps, they feel so bad after the naps, it's just not even worth it. And they'll not make a point of integrating those into their routine. In type 1, regarding the quality of sleep, they fall asleep very quickly. Sleep onset is rarely a problem in type 1 narcolepsy. They tend to have very vivid dreams. They have frequent hypnagogic hallucinations. So these are dreamlike hallucinations. They can have sleep paralysis where they wake up and they can't move. And then they can wake up just spontaneously through the night. But many people with idiopathic hypersomnia say that once they fall asleep, they are out and they just sleep like a log through the rest of the night. So anyway, bottom line is few people with NT2 and IH really fit neatly into one or the other category. And so diagnostic confidence can be low. And I can tell you a lot of, if not most of my clinic notes say things like possible NT2, possible IH. And I think it's important for me to put those in the notes because it always makes me wonder, it's like, keep an eye open and maybe rethink this every year or two, just in case there's some new data that comes up that helps square things away. As we already talked about, some people with type 2 can have severe sleep inertia. Some people with idiopathic hypersomnia can have vivid dreams and hypnagogic hallucinations. And those even occur in the general population. It's just that they're really frequent in narcolepsy type 1 and less so, much less so in IH. And as I mentioned earlier, sometimes the actual clinical diagnosis that goes into somebody's clinic note is swayed by, just needing to, we need something easy to communicate with other people, right? So you need a note for your employer, if it's kind of like, I don't know, maybe narcolepsy, maybe IH, maybe we'll just say narcolepsy just because they'll get it better. Or maybe just because that's what's needed to get the insurance coverage. It's not very scientific, but it gets the job done. All right. So as I mentioned, there's a lot of blurriness around these diagnoses. And in the end, the actual name isn't really what matters. What matters is getting your symptoms addressed. And so I think in the end, what you really want to do is make sure that your caregiver is hearing from you about what's really impacting your life and that you get the right kind of treatments for that. And so, for daytime sleepiness, we always want to make sure people are getting plenty of sleep at night, that they're taking daytime naps if the naps are helpful. Sometimes they're not in IH, but they often are in type 1 narcolepsy. And, maybe they'll need actually, most of the time, a medicine may be needed, like modafinil, amphetamines, pitolisant, solriamfetol, and oxybates. For cataplexy, we often treat that with antidepressants like venlafaxine or fluoxetine. Pitolisant can also work, as do oxybates. We don't usually give medications for hypnagogic hallucinations or sleep paralysis because the events are kind of brief and self-limited. I mean, they're disturbing, that's for sure. But sometimes just sort of, discussing the symptom and counseling people on them can help. Every once in a while, if somebody's having just vicious hallucinations, we'll use antidepressants, which can help suppress them a little bit. The fragmented sleep actually certainly improves with oxybates where people have better sleep continuity. Sleep inertia in the morning is really tough. There's not been a lot of research on this. And so clinicians are kind of going by just sort of ad hoc solutions. One thing that sometimes people do is if you got to get up at 7, you set an alarm for 6 and you take your first wake promoting meds there with the hopes that they're going to really be kicking in by 7. Something else that I've heard some docs talking about is using a delayed release methylphenidate. You take it at bedtime, but the drug doesn't actually get released until many hours later. That's called journée PM. And then it releases the methylphenidate starting in the morning and across the day. I know for a lot of people, brain fog, where you're not really thinking clearly, is a big problem. We don't know what causes this. It's really hard to pin down. I think to a great degree, it's driven by the degree of sleepiness, and that if people are really alert, they have less brain fog. And so in general, we would try to go after that by using the daytime medications, the wake promoting medications.
Dr. Scammell, pardon me, we're getting close to the time and I want to be considerate of your time too.
Sure. I have like 3 more slides.
Yeah,
Monica,
no,
you tell
that's
me
great.
what you want to do.
I'd like to see them. I think we've had a steady, participant group, and I think that we'd like to see them because I think we could all stay on longer, but if you don't mind, that would be great.
I have time. And so
Okay.
People need to peel off at this point. No hurt feelings there.
Okay.
But I do want to, it's all easy to talk about symptoms in a very clinical way, but of course that only scratches the surface of the impact of narcolepsy. And it's really, narcolepsy impacts people's lives in so many ways. And so I think it's really worth thinking about the social impact. And so last year we published a study, which was an online survey of over 250 adults with type 1 and type 2 narcolepsy. On average, these folks are 29 years old and 87% of them were women. A lot of them did report depression. And again, this is a question of like, how much is the depression secondary to the narcolepsy? How much might it be contributing at some level to some of the symptoms? We don't know. But everybody, 99% said that, oh, that's a typo. It's supposed to say narcolepsy. 99% reported that their narcolepsy made their social lives harder. The big things were the sleepiness. Oh, I'm sorry. This slide was not updated because it's showing some IH stuff. Because long sleep is not, sorry, that's a mistake. But the quotes are correct. And so on the right there, you can see people commenting on how the specific impacts where they say, I stopped going out and drinking because of my medications and I've lost some friends. I disclosed my diagnosis to sexual partners because my cataplexy almost always flares up during sex and it can be alarming to people who don't know to expect it. And my social life has fallen to almost nothing. And if not for my wife, I feel like I would be completely alone. And so, I think these are really sort of moving comments. And so these impacts on social life, relationships, sex lives, and so forth are something that I think has not gotten as much attention as it should. Idiopathic hypersomnia also has a bunch of social impacts. This is a smaller study that we're just finishing writing up right now. This is a little more than 100 people with IH. Again, we focused on young adults. And again, there was these overlaps with depression and anxiety. And I think some of these are consequences of the IH. But again, they all said that it really had an impact on their social lives. Sleepiness, long sleep, and brain fog were big. But both for narcolepsy and for IH, it was actually heartening to see that a lot of these people were in romantic relationships. Even though it was hard to get out and do stuff and have a lot of friends, they focused on the relationships that mattered most to them and the people that they're close to. And so, a lot of them were married, a lot of them were living together. But they also said that the IH also impacted their sex lives too. And you can imagine sort of all the different ways. And so, one person talks about, I don't know if my IH is a cause of my depression or if IH is a side effect of my depression. One often seems to feed into the other quite often. To be frank, there isn't time for a social life when you're sleeping 12 to 18 hours a day. That's pretty clear. I rely extra on my partner to complete some tasks so I can reserve some energy for social activities. And that's something we hear a lot, both in IH and narcolepsy, where they really do get support from that person who's close to them because they only have a finite amount of energy each day. So, how can we help out on the social side with this? And certainly optimizing the medicines to fit in with your daily life, whether it's doing well at work or school or driving, for instance, in the case of driving, sometimes we'll have somebody take a short acting wake promoting medicine just before they hop in the car to drive home at the end of the day, if that's a problem. Can we time medicines around the times when they're likely to be socializing? Certainly getting advice from other people with similar symptoms is good. Of course, Wake Up Narcolepsy is good for that. Narcolepsy Network, Hypersomnia Foundation. And I say maybe online groups, and I think a lot of people do benefit from those. I guess I just worry that sometimes, sometimes it's great advice, sometimes it's not so great advice. And so you might want to, share that with other folks to just make sure you're getting the right kind of guidance. Cognitive behavioral therapy. There's been a couple of papers written on this recently of how this type of psychological therapy can be helpful in both narcolepsy and idiopathic hypersomnia. And this kind of therapy, works on issues around your self-identity, your self-image, your daily routine, your coping skills and social support. And it can even help sort of, address legal and occupational issues that might come up with the sleep disorder. And of course, you want to talk to your provider who's helping manage your sleep disorder. We asked people, has your doctor asked about the impact of narcolepsy or IH on social life? And basically about a third of patients said yes. But when we asked, do you want your doctor to ask about it? About 70 to 73% said yes. And so I think, I don't know if doctors are actually going to start doing this spontaneously, but as a patient, if this is important to you, don't feel shy about bringing up some of these topics. Okay, we're in the home stretch here. So for the future, we need to think about better ways of really identifying type 2 narcolepsy and IH. I think for narcolepsy type 1, we've got some good solid things like measuring orexin levels, but for type 2 and IH, we don't. And so I've said this in some other talks previously, but for elderly people who are, perhaps going to die in the next 10 years, we like to sign them up for brain donation because we want to examine the brains of people with type 2 and IH. We should maybe be looking at spinal fluid more often in these disorders for other things, not orexin necessarily, but maybe we can find other clues there. And maybe we can measure stuff in blood or spinal fluid looking for chronic inflammation, or maybe there's other things that I haven't thought of. Also, we should be doing what's called prospective studies where we follow people, once a year and sort of see how the disease goes, because we don't even know. I mean, really, there's sort of anecdotes around this, but we don't even know if idiopathic hypersomnia or type 2 get better in time. And then we need clinical studies that also target some of the other endpoints that I think are less common and not typically addressed in the typical drug studies. What about sleep inertia? What about brain fog? Can we come up with therapies that really target those in an effective fashion? All right. So the main points that we've talked about are, I just want to emphasize that in the end, these diagnoses of type 1, type 2, and IH, they're just medical categories. And we, of course, need to do more work to really try to define these better, come up with better handles on pinning them down. But in a way, you are who you are, and everybody's unique. And what really matters is that you share what matters to you with your treating provider and that you get treatments that are really tailored to your symptoms. And I think we need to do better in terms of finding meds that target the obvious symptoms like sleepiness and cataplexy, but also think more broadly about, people's daily lives in other ways. And how can we maybe help with that better than we are now? And as I mentioned, the doctors that you're working with might not be aware of these broader impacts of narcolepsy and idiopathic hypersomnia. So I would encourage you to try to, bring up these issues when you go into clinic. Write up a list beforehand, bring a friend or a relative or spouse, because, I think having, being able to sort of share your experience better with your provider is a good way to actually obtain those better treatments. Okay, well, I'm going to wrap up with that. I still see there's a bunch of questions that we haven't addressed, so I'm going to stop sharing my screen. But I'm happy to kind of go through some of the questions now, Monica, or do you feel like we can close out?
No, I think that would be great if you could. I think the information was excellent, and I think if we could just quickly go through these, that would be wonderful.
Sure. Okay. So Susan asks, what are the side effects of long-term modafinil and Adderall for narcolepsy type 2? And that's a great question. I get asked this a lot in clinic, and we don't know. I mean, I think I can say safely, it's like, there's nothing that sort of screams out as being necessarily problematic, but there's not a lot of studies other than the formal drug studies of, where they follow people for a year or so. But we don't know what 5 years, 10 years, 20 years of drug use is going to do. I do think that for some things that we know can increase blood pressure, like Adderall, it's really important to monitor blood pressure. In narcolepsy, people are more prone towards having high blood pressure. And so I'm checking that much more carefully and consistently than we used to. But I'm not, some people say, well, does it cause any brain injury over time? And I don't really think there's any evidence for that. So, all right, somebody asks, how do you counsel patients that have experienced clinically recognized remission or spontaneous remission of narcolepsy type 2? I'm not sure what this means, i.e. on the possibility of returning. Well, journals like Nature have published case studies on SR cases. Oh, spontaneous remission. The information available is almost non-existent. Yeah. So I think, so in narcolepsy type 1, I don't think there's any cases where somebody has really spontaneously gotten better. In narcolepsy type 2 and IH, I think sometimes people do get better. And without knowing what the actual cause is, it's really hard to give any advice on the likelihood of the sleepiness coming back again in the future. I have to say, I have no great opinion on that. I mean, I think it's a good question, but again, this is just another piece of evidence that we really need good longitudinal studies to get a sense of this. Even after people get better, they should continue in the longitudinal study and see if their sleepiness comes back again. And if so, what might that be associated with? Okay. Somebody asks, oh, this is complicated. Somebody's asking, what's the difference between venlafaxine and desvenlafaxine, and why is venlafaxine approved to treat cataplexy and desvenlafaxine isn't? I'm not sure that either of them is actually FDA approved for that purpose. Most of the antidepressants that we use, we're using because we've had experience in clinic that they actually work, but we don't have great giant clinical trials for that. Okay, Matt asks, actually, I think it's more of a comment. He says, Dr. David Plant wrote a meta-analysis on sleep architecture and idiopathic hypersomnia. How different is sleep architecture in IH compared to normal sleep? And he cites the paper. I think it would take me a little while to kind of scroll through that again, but Matt, my recollection is that people with IH tend to have pretty long sustained sleep. There may be fewer spontaneous awakenings, but thanks for flagging that, because I haven't looked at that paper in a while, and that was a good reminder to go look for more objective evidence. Okay, somebody asks, we often speak of excessive daytime sleepiness. Yes, but it is this rapid sudden wipeout of going to sleep suddenly without warning at my desk that's my biggest bugbear. And the fact that people don't understand or unfortunately don't want to. Yeah. So sleep doctors just kind of use the term excessive daytime sleepiness as if it sort of means something, but it really captures a lot of different stuff. And I think that this idea of just kind of losing it, where you're working, and then before you know it, you just find yourself nodding at your desk. It certainly happens. And you could call that a sleep attack, to be honest, where you really weren't intending to go to sleep at all, but it just happens. And certainly when that sleepiness comes on, it can be very hard to resist.
Yeah. How are you doing, Dr. Scammell? Are you?
I'm fine.
Okay.
I see a couple more that I think would probably be good.
Okay.
Laura asks, is narcolepsy linked with high creativity? And yes, there's a really neat article from Isabel Arnulf that touches on this. And I think this is the only good thing I can say about narcolepsy, because it's kind of cool to think that perhaps all those vivid dreams and wild thoughts through the night actually do contribute to better creativity during the day. It'd be interesting. I'd be curious to hear sort of from patients more casually if how they feel about their creativity. Okay. Somebody says, I have idiopathic hypersomnia and a good specialist. We've tried every kind of stimulant drug on the planet, now gone full circle, currently on modafinil, but have also have trazodone sleeping at night, and I just live with it. Oh, I reckon it's linked with depression. Is when my day is not going well, my idiopathic hypersomnia is also bad. Do you agree? Yeah, well, I think everybody's individual on this. And I do think that, depression can make people tired in different ways. And so if somebody's, if somebody's got some depression that's running along with their idiopathic hypersomnia, we've got to make sure that both are getting attended to. Giving somebody, a wake promoting drug alone without, addressing the depression with some kind of therapy or medications you might be missing out on some important things, because ultimately we want to, get people feeling and performing as well as they can. So yeah, I certainly agree there's some synergy there. Okay. Oh, somebody says creativity is my strength as an artist. Thank you. Nice to hear that. Somebody says, what diet is best? And the short answer is so they're asking about the ketogenic diet. I think there's just not a lot of good formal research on this. Ketogenic diets are felt to potentially, so a ketogenic diet is essentially where you eat certain foods that make your body think you're starving, or you limit your food to only certain times a day. So you go for 18 hours each day without food. So like you eat dinner, but you skip breakfast and maybe breakfast and lunch. Yeah, there's some scientific reasons to think it improves alertness. I'm not sure if it's actually improving the narcolepsy or if it's just sort of another way of becoming more alert. But I'd love to see a good formal study on that. Okay. Somebody says, I've received some discrimination from doctors thinking that I was abusing or selling my meds. Any suggestions for helping them believe? Yeah, I'm sorry to hear that. It's hard to know how that interaction is going. I think doctors working in some parts of the country may be encountering a lot of patients where there is issues around stimulant abuse and that kind of stuff. And so they may be seeing a lot of those patients, and then that rubs off on the folks who have a legitimate need for these stimulants. I think a lot of states now have online databases where you can track when somebody's filling prescriptions. And this is actually super helpful because, at least as far as obtaining prescription medications, it allows us to sort of see, is somebody getting prescriptions from multiple providers? Are they filling their meds earlier than they're supposed to, and that kind of stuff? And so those databases can be helpful. And I think that kind of objective data may be one way of sort of pushing back with those docs to help reassure them that you're taking your meds in a responsible way. Evelyn asks a really great question, which is, can you describe fragmented sleep? And we don't have a great definition for this. It's something that's really kind of in evolution right now, where researchers are trying to come up with objective measures of disrupted nighttime sleep. And so the general feeling is that people with narcolepsy can have disrupted sleep. It can be disrupted because they spontaneously wake up. It can be disrupted because they have really intense hallucinations or sleep paralysis that rouses them from sleep. They might also have concomitant sleep apnea or other things. But there's something probably fundamentally fragile about sleep, especially in narcolepsy type 1, where people just pop awake. It's the weirdest thing, since they can easily fall asleep during the day. But you might actually just sort of imagine that whatever it is that sort of helps control switching between sleep and wakefulness, that little switch may be somehow delicate in narcolepsy, where people can easily cross that boundary. So I think in terms of clinical practice, just tell your doc what your experience is. And, it's possible those might provide clues as to identifying a treatable cause of the fragmented sleep, or at the very least, it helps give some insight into whether you might benefit. If your sleep is really fragmented, maybe that would be an argument for considering an oxybate or something like that. All right, I'm going to do a couple more. Mm-hmm. Oh my goodness, so many good questions. Somebody says, I have type 1 narcolepsy. And My cataplexy did not begin until a couple of years after onset. Pitolisant has really improved this. That's great. Have you seen worsening narcolepsy symptoms in post-COVID patients? No official data on this. It's something that people have looked at. I don't think there's a clear pattern, but it's a really good question because I didn't really get into this, but narcolepsy type 1 is felt to be due to an autoimmune attack on the orexin neurons. I mean, it might be normally triggered by strep or flu or something like that. And in Europe, 10 years ago, was triggered by a type of flu vaccine called Pandemrix. It's possible that any sort of inflammatory thing might be enough to stir it up, and COVID could do that. I'm not aware of any sort of particular increase in the incidence of narcolepsy following the COVID pandemic. But, you know, if you've already got kind of medium bad narcolepsy and then you get COVID, maybe that additional inflammation could kind of kill off a few more orexin neurons. But again, that's just guessing. Somebody asks, is weight gain common for untreated narcolepsy? And the answer is yes. People with narcolepsy, on average, tend to have a body mass index, okay, sort of a ratio of weight to height, about 20% higher than the general population. We don't know why this is. The not so great research that's been done thus far suggests that people with narcolepsy eat about the same amount as other folks. They exercise about the same amount, but they still gain weight. And so it's possible that your metabolic rate is lower when you have narcolepsy. And so 1,000 calories for you means gaining more weight than 1,000 calories for somebody else. It's just people with narcolepsy need to be sort of especially vigilant about what they're eating and making sure that they are getting at least some exercise. It doesn't need to be a lot of exercise, but just a modest amount.
A lot of great feedback about you, Dr. Scammell, too. I think many people
read
want you
those.
as a physician. You weren't going to read those, but no, it's great. And people like you give us hope. And, you know, people want to know if they're able to contact you but, you know, would like you for their doctor and things like that. So I agree to all of those. This has been incredible.
Well, thanks for all the engagement. I appreciate people's comments. There's a lot of smart questions there, and it's good to see that people are already thinking about this very deeply.
Mm-hmm. Definitely. So thank you very much again. I'd like to finally thank you again and the sponsors for bringing this to the community. And those are Avadel Pharmaceuticals, Harmony Biosciences, Jazz Pharmaceuticals, Takeda Pharmaceuticals, and Centessa Pharmaceuticals. So thank you so much, Dr. Scammell. This was incredible. And it's a testament to the number of people who have stayed on past the three o'clock time. So we'll have this in a webinar recording and shared with everyone and on our YouTube channel as well. So thank you very much. Have a great day, everyone.